How's it going, guys? Past level question, endocrine step 1, family internal medicine 2CK. 26-year-old woman. She clearly has hyperthyroidism here, restlessness, palpitations, heart rate's elevated. And I gave you the TSH that's low. I understand you don't have the normal ranges in front of you, but for 2CK especially, you got to know 0.5 to 5.0 is the normal range for TSH. Not dramatic, okay? Stop complaining, take your training wheels off. Radioiodine uptake scan shows reduced uptake. Okay, so holy shit, we have hyperthyroidism, but uptake's reduced? Question mark? Okay. So let's just look at the answer choices here. Choice A, antibodies against TSH receptor, wrong fucking answer, refers to Graves' disease. So if we had Graves' disease, although yes, we'd have hyperthyroidism with a suppressed TSH, our radioiodine uptake scan would show diffusely increased uptake. Wrong fucking answer. Choice B, antimicrosomal antibodies, wrong fucking answer. So this refers to Hashimoto thyroiditis. These are AKA anti-thyroperoxidase antibodies, can also have anti-thyroglobulin. So you'd have hypothyroidism, your TSH should be elevated, and you'd have, as we have here, diffusely or just reduced uptake into the thyroid gland. Wrong fucking answer. Choice C, exogenous administration, levothyroxine, just T4, wrong fucking answer. So this patient, the reason it's wrong, now some of you are going to get emotional right now. If you're exogenously administering thyroid hormone, aka surreptitious thyrotoxicosis, aka factitious thyrotoxicosis, you would have suppressed TSH and you would have reduced uptake in the thyroid gland. So some of you are confused right now. Well, we've got neck tenderness. So that's not classic for exogenous administration. It's not part of the vignette. So we don't disregard this answer choice 100%, but we don't classically get neck tenderness. So we're going to continue looking at the other answer choices and see if there's something better. Choice C, wrong fucking answer. Choice D, increased release of preformed thyroid hormone, correct answer. So as I've talked about in other clips and in my PDFs, you need to know that a tender/painful thyroid is dequervating thyroiditis till proven otherwise, aka subacute granulomatous thyroiditis, aka just subacute thyroiditis. So you need to know those different names. So what it's going to be is classically a viral infection. They'll only mention the viral infection as per my observation across NBME exams maybe a quarter of the time. So you can't rely on that as a crutch. We look at this vignette here and we've got neck tenderness, very buzzy for dequervating. We have hyperthyroidism and we have reduced uptake. And the reason we have reduced uptake is because the mechanism is inflammation of the thyroid gland. We have increased spacing between the follicular cells. We have increased release of thyroid hormone into the blood. That's what's occurring. But we don't have increased production of new thyroid hormone. That's why our uptake is low. Okay, so increased uptake denotes increased production of new thyroid hormone, which as I just discussed, we don't have here. So high yield point, let's look at the final answer choice, toxic adenomatous autonomous secretion, very verbose answer choice, wrong fucking answer. This would refer to a toxic adenoma. Okay, so toxic adenoma, although hyperthyroidism, we'd have suppressed TSH, we would have a radioiodine uptake scan showing increased uptake into a focal area of a nodule. Wrong fucking answer. You know the deal. Until you make more content, building stuff, Scrum. Appreciate your time. That's a